Hello and welcome to my YouTube channel. Today we would be discussing about important updates regarding thyroid carcinoma. And this update I am going to tell you according to the 2025 modification of American Thyroid Association guidelines. Now there are few important updates or changes which have occurred since the last guideline which was formulated in 2015, and this recent guidelines which was updated in 2025 focuses on very key aspects of management of thyroid carcinoma. So let's go into brief detail about the what are the updates which have occurred according to American Thyroid Association guidelines 2025. What changed in the 2025 update? The first one is the individualized shared decision making. That means it replaces the one size fits all protocol. Patient values and anxiety tolerance is also weighed alongside the evidence. So that is very, very important, and that is the key update. Second one is the expanded molecular diagnostics. That means the genomic profiling informs the surgical extent and is mandated before first line therapy, especially in radioiodine ablative therapy refractory cases. Now, the most important update in 2025 is four-tier risk stratification. And this four-tier risk stratification replaces the 2015 three-tier system. And what are these four-tier risks? We'll see in detail in subsequent slides. Number one is low. The second one is low intermediate carcinomas, intermediate high carcinomas, and high carcinomas. So these are the four-tier risk stratification which has replaced the earlier one, three-tiered. Expanded role for lobectomy and active surveillance. Comparable outcomes, it has been found, could be achieved for patients with total lobectomy alone, especially in low risk cases with very few complications, as compared to doing a total thyroidectomy for low risk cases. So this is another major update which we will discuss in detail. Percutaneous ablative therapy or percutaneous ablation is introduced as one of the important primary treatment alternatives to surgery, especially for selected small low risk tumors. And finally, the de-escalated surveillance. Long-term excellent responders can step down and eventually they can de-escalate, or they can go out of the radars of active surveillance. The time frame has been expanded. We'll see what are the time frames. Let's go into the details now one by one. The first and foremost in the preoperative evaluation of the patient is the neck ultrasound. The neck ultrasound. Now, this neck ultrasound is now made mandatory for all thyroid nodules. This ultrasound would assess not only the primary tumor in terms of its size, the location, but it would also tell the clinician about gross extrathyroidal extension into the surrounding tissue, and also the central as well as lateral compartmental neck nodal status. So neck ultrasound as a pre-operative workup is one of the mandatory requirements now. Number two, FNA cytology, fine needle aspiration cytology. Bethesda based cytopathological analysis of all thyroid nodules, which meets the size as well as sonographic risk thresholds. Indeterminate categories drive further workup. So FNAC plays a very important role, and normally, as all of you are aware, we use a Bethesda system of cytopathological analysis of any thyroid nodule. Routine preoperative thyroglobulin measurement is not recommended as a diagnostic or staging test before any initial surgery. That is one very important thing to remember, that we don't do a routine preoperative thyroglobulin studies as a preoperative workup. And preoperative genomic testing is again not done routinely, but where readily available, it can be done. Results may be weighed with clinical, sonographic, and cytological findings to help decide the exact extent of the surgery. So it should not be routinely done, but if it is widely available in a particular center, then it can be done, but the results have to be weighed along with other parameters. Molecular testing has got two distinct roles. One is before initial surgery and one is before systemic therapy. Before initial surgery, routine genomic testing is not advised, which we have already seen. But if it is already available, it may refine the extent of surgery decisions alongside the other parameters like clinical radiographic and cytopathology. And giving before systemic therapy, comprehensive molecular profiling is now recommended for radioactive iodine therapy which are refractory to those radioactive iodine. In such cases, we can do a genomic testing to select the final treatment pathway for such cases which are refractory to radioiodine ablative therapy. Now, this is a very important update which I'll focuses on the extent of initial surgery, the surgical management. Now, decision is driven by shared decision making. It depends not only on tumor size, but also its features plus the patient's sex, family history, and radiation exposure history. So, what it means is that whatever surgical decision about the extent of surgery is taken, it should take into consideration not only the tumor size itself, but also the other parameters regarding the patient, like the sex of the patient, the age of the patient, the family history, the radiation exposure, and based on that, the extent of surgical treatment should be taken into consideration. Now let's go into the detail. Tumor profile. That means if the tumor size is less than or equal to 1 centimeter, which we categorize as T1A, with clinically no cervical lymph nodes, N0, and no gross extrathyroidal extension. In such a case, the recommended approach is lobectomy. Lobectomy, that means you remove the affected lobe only, and maybe the isthmus. So lobectomy plus isthmectomy if surgery is chosen in such a cases. Active surveillance or even percutaneous ablation are appropriate alternatives also in such cases where the tumor size is less than or equal to 1 centimeter, or there are no nodes, cervical nodes, and there is no gross extrathyroidal extension. Now we go to tumor profile, where the size of the tumor now or the nodule increases to more than 1 to up to 4 centimeters. That is 1 to 4 centimeters, but it is still confined to one lobe. That means it is not multicentric. In such a case, the recommended surgical approach is we can do a lobectomy plus isthmectomy, or we can also do a near total or total thyroidectomy. Now both options are available here, lobectomy as well as total or near total thyroidectomy. Now the lobectomy alone is adequate for low risk papillary thyroid carcinoma or follicular thyroid carcinoma. Total thyroidectomy is chosen to facilitate any ablative therapy which may be required later on, and it also aids in surveillance, and it can be used as per the patient preference. And lastly, if the tumor size is more than 4 centimeters with gross extrathyroidal extension or node positivity, in that case we don't have any other choice but to do a total thyroidectomy. This is associated obviously with worse outcome if treated with lobectomy alone. So basically it is divided into two parts. If the tumor is less than 1 centimeter or between 1 to 4 centimeter with no nodes, no gross extrathyroidal extension, we can do either a lobectomy like in 1A, or we can do lobectomy plus total thyroidectomy, whichever we choose depending on patient's preference. But any tumor more than 4 centimeters with gross extrathyroidal extension or even a node positivity, we have to do a total or near total thyroidectomy. Now, what is the key shift here from 2015? Lobectomy is now positioned as an acceptable and often preferred initial operation for a low risk disease. What is a low risk means? That means there is no extrathyroidal extension, there is no extrathyroidal extension or node positivity. In such cases, we can do a lobectomy up to a tumor size of up to 4 centimeters, and it was initially the initial update was any tumor less than 1 centimeter we used to do lobectomy, and any tumor more than 1 centimeter we used to do total or near total thyroidectomy. But now the key shift from 2015 is even up to tumor size up to 4 centimeters, provided it is low risk. That means there is no extrathyroidal extension, no node positivity. We can still do a lobectomy. So lobectomy has become a more like a wider net as compared to the previous update. Now, for low risk disease, what is low risk disease? And active surveillance and percutaneous ablation. Formally endorsed as a primary treatment strategy for selective CT1, clinical T1A, that means node size, tumor size less than or equal to 1 centimeter, with no node positivity and no extrathyroidal extension, papillary thyroid cancer, with oncologic and quality of life outcome comparable to immediate surgery. So what is the active surveillance protocol which we can use in such low risk cases? Number one is ultrasound every 6 months for 1 to 2 years. Then annual ultrasound by an experienced sonographer later on. Thyroglobulin measurement and antibodies monitored alongside imaging. Crossover to surgery if there is an increase in the size of the node, or if there is an extrathyroidal extension or node positivity occurs, or if the patient's preference changes, then you can cross over. So till that time, in a low risk case, we can do active surveillance protocol. What are the favors, who all will benefit from this active surveillance in a low risk case? Any patient who has got older or elderly patient with significant comorbidities who may not be able to tolerate extensive surgery. In such cases, this active surveillance protocol can be used in low risk cases. Tumor which is away from trachea or recurrent laryngeal nerve, low patient anxiety, and the follow-up is reliable. Access to serial ultrasounds or distant residence favors earlier surgery instead. Okay, percutaneous ablation by radiofrequency ablation or laser therapy is a new alternative to surgical therapy for selected low risk T1A tumors where the size of the tumor is less than or equal to 1 centimeter. All the benefits, the risks should be discussed with the patient before this treatment of percutaneous ablation by RFA or laser can be taken in low risk cases. Now, American Thyroid Association, we have already seen, have updated the previous 3-tier risk stratification system to 4-tier risk stratification. Now, what are exactly are these 4 tiers? One is low, second is low intermediate, third is intermediate high, and then high risk. What is low risk? We have already seen low risk cases are intrathyroidal, number one, papillary thyroid carcinoma with no or minimal aggressive histology. There is no nodal invasion and no vascular invasion, no extrathyroidal extension. Such cases are considered as low risk. What is low intermediate? There is a minor extrathyroidal extension, low volume, node positivity may be 1A or 1B, ipsilateral mobile or fixed, or limited vascular invasion. In such a case, we categorize it as a low intermediate. What is intermediate high? Aggressive histology, that is very important, higher nodal burden, and more extensive vascular invasion. And what is high? There is a gross extrathyroidal extension. There may be an incomplete resection from the initial surgery, any evidence of distant metastasis, any high-grade histology or extranodal extension would be categorized as high-risk case. So there has to be a gross extrathyroidal extension with a very unfavorable histology with extranodal extensions or distant metastasis. This risk tier is combined with American Thyroid Association response to therapy status to set the intensity of radioiodine therapy, follow-up imaging, and other biochemical surveillance. So let's see how this risk stratification would help a clinician in formulating a treatment strategy. The most important adjuvant therapy in thyroid carcinoma is post-operative radioactive iodine, RAI. Now, depending on the risk category, if it is a low risk, which we have seen previously, the radioactive iodine therapy is not routinely recommended. If it is low intermediate or intermediate high, this is considered a radioactive iodine zone, and this is individualized by tumor burden, extrathyroidal extension, age of the patient, histology of the tumor. Typical activity, we give 30 microcuries, remanent ablation up to 100 to 150 microcuries as an adjuvant. And for a high or a distant metastasis, any patient who comes into high risk or a distant metastasis, it is always recommended. So in low intermediate or intermediate high, we individualize, but in high risk case, where there is a significant extrathyroid extension or lymph node positivity or distant mets, then we always recommend it. And more than 100 microcuries, up to 200 microcuries for metastatic disease should be given in post-op radioactive iodine therapy in such cases. Now, why this consider RAI zone matters? Now, intermediate risk diseases, that means low intermediate and high intermediate, no longer receives the blanket adjuvant radioactive iodine. Features that tip the decision towards radioactive iodine treatment include N1B nodal disease, larger tumor size more than 5 centimeters, greater tumor diameter, and extrathyroidal extension, balanced against unproven mortality benefit in many of these patients. So the low risk disease guidelines now recommend against routine radioactive iodine, a clear step down from earlier practice. So this is very, very important to consider. The role of post-operative radioactive iodine is definitely there in high-risk cases or in distant metastasis. Its role is not at all there in a low-risk cases, and it is no longer recommended. And in low intermediate and intermediate high cases, we always individualize, and it is no longer considered as a blanket adjuvant RAI. We have to individualize it according to the patient's tumor size. If it is more than 5 centimeters, if there's a greater tumor burden, N1B nodal disease, or extrathyroidal extension. Follow-up. How the follow-up would help in this thing? Post-operative thyroglobulin measurement now measured 6 to 12 weeks after surgery. Previously, we used to measure it 3 to 4 weeks after doing a surgery, say total thyroidectomy. We used to measure the thyroglobulin assay, and we used to say whether there's any recurrence or is there any relapse. But now the routine guideline says, the recent guideline says, it should be measured 6 to 12 weeks after surgery, reflecting an updated data on thyroglobulin kinetics. Now, years 0 to 5 to 8, standard surveillance is done. That means serial neck ultrasound is done, plus a thyroglobulin assay according to risk category. After 5 to 8 years, start de-escalating. That means if sustained excellent response, stop ultrasound after 5 to 8 years and continue thyroglobulin measurement every 1 to 2 years. And after 10 to 15 years, complete remission, sustained excellent response, discontinue both biochemical and radiographic surveillance. Lobectomy only patients, that means low risk cases or patients who have just undergone lobectomy, low intermediate risk, ultrasound every 1 to 3 years for 5 to 8 years is mandatory. If the initial study is negative, routine serial thyroglobulin monitoring is not recommended. Advanced disease, radioactive iodine refractory and metastatic diseases. Only 5 to 15% of thyroid carcinomas becomes radioactive iodine refractory or unresectable. Systemic therapy is reserved for progressive systemic disease, typically when the growth exceeds 20% over 12 to 14 months. Step 1, which is mandatory, is always, we have already seen, comprehensive molecular or genomic profiling should be done in radioactive iodine refractory disease and metastatic disease before choosing any first line systemic therapy. The first framework to directly link driver mutations to treatment choice. If there is no targetable mutation, then we can use multi-kinase inhibitors as a first line. Lenvatinib, generally preferred over sorafenib. It is reserved for progressive symptomatic unresectable disease. If there is a targetable alteration present, selective targeted therapy can be preferred as first line, example BRF or RET fusion, matched to the specific driver identified on profiling. And local therapy like external beam radiotherapy and chemoradiotherapy are used selectively for structural or local control and not as a routine adjunctive therapy. So this is for refractory radioactive iodine carcinomas and metastatic diseases. Genomic profiling should be done and it is mandatory, and the treatment should be individualized according to genomic profile. And we can use multi-kinase inhibitors or selective immunomodulators for such cases.